I wish to thank the organizers for inviting me to this webinar today, and I will be speaking on how to assess vaccine efficacy against infection and transmission for vaccines against COVID-19. So in the media, but also in the public discussion, we hear a lot a sentence similar to, we need vaccines to control and eventually end this pandemic. However, if you look at published clinical trial protocols describing advanced stage phase 3 clinical trials, they mostly assess vaccine efficacy against disease rather than infection and transmission. The primary endpoints for phase 3 clinical trials are directed against vaccine efficacy against PCR-confirmed COVID-19 illness of any severity. And they also assess secondary endpoints, vaccine efficacy, for example, against severe disease, meaning hospitalization, death. And we also see evidence accruing against the new SARS-CoV-2 variants. But we haven't heard a whole lot out of ongoing large phase 3 clinical trials on vaccine efficacy against transmission and infection. We also have to separate, when we talk about infection, we have to separate infection from viral shedding, from transmission, which is not necessarily the same. And then we have to take into account our diagnostic tools, because they are also not the same. And some are actually testing infection, of course, but the data on infection cannot directly be generalized to, for example, transmission. So if we test for infection by PCR or point of care tests, then we may generate data on infection per se. And if we do demonstrate very high efficacy against infection, this will likely also mean that such a vaccine will then prevent transmission. But on the other end, if we do not show clear efficacy against infection, for example, based on PCR, which is nothing else but showing the presence of nucleic acids in the sample, not necessarily demonstrating a viable virus. So if we do fail to demonstrate infection, that could still mean that this vaccine is effective against transmission. For example, if this is just indicating, as I said, a nucleic acid, but not transmissible live virus. So what does prolonged viral shedding, for example, mean for transmission? Again, viral shedding is the same as PCR positivity. Viral shedding has been included in some of the large phase 3 trials in case trial participants have been confirmed to be infected with coronavirus, then those are selected for prolonged PCR testing indicating viral shedding. But again, this is just prolonged PCR positivity, which does not necessarily, at least, translate into transmission. So let's have a look at some options to test infection in ongoing or planned phase 3 clinical trials, or of course, observational studies. This applies to both type of investigations. So first of all, we need to understand what is actually ongoing in a natural infection. So where is the virus present? What is the viral load? What does this mean for infectiousness in natural SARS-CoV-2 infection? We know that the vast majority of infected persons is actually asymptomatic and remaining asymptomatic throughout. We learn more and more about infection characteristics across age groups. We know that the transmission can occur among children and adolescents, but they are less, they're at lower risk for symptomatic disease. We also, from those investigations into natural infection, have to learn more about the appropriate sampling. Will we perform, for example, testing in clinical trials based on self-testing, or will we require trial participants to actually show at trial sites to have some professional healthcare worker perform the testing? It is clear that a nasal swab can potentially be done by a layperson, but a pharyngeal swab is quite difficult to do on yourself or on your nearest. This is something that has to be done by trained healthcare professionals. To test for infection, meaning to include asymptomatic infections where you do not have clinical symptoms that trigger certain investigations, you are left with continuous, for example, weekly testing in healthy trial participants. Obviously, given the large size of phase 3 trials that we currently see, 40,000 subjects, this will result in very large numbers of tests, which again have implications for logistics and costs and many other aspects, as I will show in a second. In principle, quantitative RT-PCR has a very good sensitivity and specificity, but as said, capacity might be limited or a limiting factor. And an alternative approach would be an antigen point of care test. However, they have some detection limits. They have a lower sensitivity and specificity. There is a higher risk for false negative results, and this may be insufficient to truly test infection, as point of care test may remain negative, although a specific trial participant is actually infected, but they may still be a good indicator for transmission, because there is some evidence indicating if an antigen point of care test remains negative, that particular person is also at very low risk to pass the virus beyond. Test sensitivity, let's have a brief look into this because it is obviously very relevant. Let's assume that the test sensitivity is 99.9%, so really high, but there's always something that can go wrong even for RT-PCR testing. Let's assume you have a trial of 10,000 subjects and you will have to do weekly PCR testing for over 25 weeks. That will result over time, assuming you have a good compliance with in your trial, that will result in 250,000 PCR tests. And even with the 99.9 sensitivity, this will result in 250 false positive cases, which, depending on the incidence, may even outsize the actual number of true infections. Finally, it is important to assess and investigate into the appropriate and most promising type of specimen, nasopharyngeal swabs, saliva, as well as storage conditions and shipment conditions. Let's have a look at one of the trials. I'm sure many of you will have seen these data, which have been published. One of the trials that have actually performed weekly self-swabbing and then followed by RT-PCR testing for asymptomatic infections. This is the trial that was conducted by the Oxford University with the Oxford AstraZeneca vaccine in the United Kingdom. In red, you see data from the asymptomatic testing. So this is the results for the weekly self-swabbing and RT-PCR. And the lower panel is the results that have been published on clinical disease. So where you had an indication or indicative signals and symptoms that you would then that would then trigger test, which are obviously a higher positive predictive value. And this is then what was used for the primary vaccine efficacy objective. But let's have a look at the data. As you know, in this trial, there was a low dose, standard dose regimen tested and a standard dose regimen. And you can see, let's start with the lower panel, that the overall vaccine efficacy against COVID-19 illness was about 74%. It was higher in the low dose, standard dose regimen, but there's also some evidence indicating that the true advantage was actually that the low dose, standard dose was given at a larger interval. So it's probably the prolonged interval that has resulted in this higher vaccine efficacy against disease as compared to the standard dose regimen based on a shorter interval. But on the upper panel in red ink, you can see that the vaccine efficacy against asymptomatic disease was much lower. So what we can learn from this is that efficacy against disease does not necessarily mean that a vaccine also protects against infection. Let's look at an alternative option instead of doing direct virus diagnostics in clinical trials on a weekly basis. Most vaccines are based on the spike glycoprotein, either using the full length or the receptor binding domain of this antigen. So seroconversion to an antigen that is not included in the vaccine is one option to test indirectly infection as well. And since most vaccines are based on the spike glycoprotein, an antigen that is offered for seroconversion is the N protein. However, the N protein is a much smaller protein as compared to the spike glycoprotein and has fewer epitopes. It is a non-neutralizing protein, and it has a shorter half-life, only 60 days. So the antibodies against the protein, that's what's meant. The antibodies against the N protein have a shorter half-life of just 60 days as compared to the 120-60 days observed for the spike glycoprotein. And the advantage of testing seroconversion to the N protein is that you don't have to do this on a weekly basis. So you don't have to do repeat, or you will not generate a comparable number of tests, which has an advantage with respect to false positive results. But you still have to consider the test frequency, accounting for the shorter half-life. And it's probably insufficient to just test at baseline and the end of the study. You will probably have to test more frequently. And in the little table on the right upper side, I'm showing you the test frequency that is being published from these vaccine developers when they released their protocols. So you can see that they actually test much more frequently than just at study start and study end. What is complicating this a little bit further is that there's at least some described cross-reactivity with normal circulating human coronaviruses, which again complicates the interpretation of seroconversion to SARS-CoV-2 N protein further. And it is clear that those vaccine candidates that are based on whole variants, or that actually include the N protein as an additional antigen, this strategy will not work, as the vaccine itself will generate antibodies against the N protein, which does no longer allow the use of this seroconversion test to assess infection or natural infection. So what is additional evidence or evidence beyond clinical trials that we will see or that we will have to look at? We can do modeling based on certain assumptions, and we have had a discussion with Neil Ferguson in London, and I'm quoting some of his comments and observations. So even with a very high coverage of a vaccine that gives a very high efficacy against disease, ongoing transmission can cause very high mortality in the remaining 20% if the vaccine does not prevent transmission. So it is obviously an important factor to have a high rate of transmission, of protection against transmission as well. And even if vaccines do offer a high efficacy against infection transmission, for example, 90%, then still very high coverage in the general population will be necessary to stop transmission. We hear sometimes that given the R0 that has been described for SARS-CoV-2 transmission, we need a 60 or 70% seropositivity in the population to eventually stop the epidemic curve. However, this is based on the assumption that seropositivity does translate into sterile immunity, so complete protection against infection and transmission. Then you can still have around 40%, 30% of the population seronegative, and the pandemic will still end eventually. However, it is unlikely that vaccines against SARS-CoV-2 infection will provide a sterile protection. And that, in my view, means that the actual seropositivity rate has to be much higher as the 60 or described 60, 70% to really have an effect on transmission beyond the promising evidence we have seen against disease. I would not want to deep dive into statistical considerations with regard to transmission studies. Just to mention a few options that we do have and that are currently being discussed and also implemented moving forward. There is studies that can be done based on randomized or observational design. We can perform household transmission studies or small mixing groups. We can do contact studies at individual levels, but we also prepare, and the WHO is discussing trial design based on larger scale population studies, including cluster randomized studies, for example, with a stepped wedge trial design or cluster observational studies to assess vaccine effect on transmission on a population level. A few additional aspects that I'd like to mention. There is a few countries that have advanced already with vaccination coverage. We are in particular looking at evidence coming out of Israel, where far more than 30% of the population has by now been vaccinated. First data have been released from Israel demonstrating a good efficacy against infection. I'm not entirely clear if this is clearly separating disease and infection based on the reports that I have seen, but at least there is promising data indicating that vaccination does have an effect on transmission as well. So we have to stay tuned. More data will certainly be generated and be released in the near future. Obviously, it's unclear what all this evidence that has been generated last year, where we had a perfect match between circulating virus strains and strains included in the vaccine. We'll have to see how this evidence, including infection and transmission, translates for the new variants that are currently circulating. We have to make sure if we do weekly testing, for example, based on antigen point of care tests, we have to make sure that those tests also cover the newly emerging variants. And we should be doing genomic sequencing in case we have tested someone positively. Is there a role for controlled human infection models? This is being discussed currently. It has been discussed last year. Some of the groups preparing controlled human infection models are now developing GMP-conform infection material covering the newly emerging variants as well. An objective could be mucosal replication, for example, could be infection per se, so positivity post-challenge, but I don't expect that controlled human infection models will be started within the next few months. Obviously, the vaccine effect on infection is also being tested in animal models. I don't want to go into details here today, but there is a lot of evidence, and there's more evidence being generated currently. For example, post-challenge and then transmission from vaccinated animals from one to another. There is models that have been established, but you can obviously also assess viral presence in the upper or lower respiratory tract post-vaccination and then post-challenge. And those data are so far also promising, but it is obviously not entirely clear how far these data can be generalized to the human situation. Let me end this presentation with a few final considerations. The evidence on vaccine efficacy against transmission and infection is obviously very important. This will have a huge impact on public health and vaccine recommendations. But let's be realistic first and be happy that we have demonstrated vaccine efficacy against disease. This is a little bit similar like the influenza situation, where we have been using vaccines for decades, and we have not even made major changes to the vaccine for the Northern Hemisphere, at least since 2009 for the H1N1 component, but we have not prevented seasonal influenza, even with our vaccine, vaccine rollout. So vaccines, the primary aim for vaccines is to prevent severe disease, to prevent people from hospitalization and death. And that is our primary goal. And we should keep this in mind. Obviously, if beyond vaccine efficacy against disease, we are able to achieve vaccine efficacy against infection transmission as well, that would obviously allow us to replace the non-pharmaceutical interventions like face mask and so on earlier. But even without that effect, vaccines are urgently needed. One has to debate if an intramuscular injection generalizing a systemic immunity will really be suitable to protect across the mucosal membrane against infection in the upper respiratory tract. This, as you know, is not the case, for example, for influenza vaccines. And still, they have an important role in public health. Will vaccines, in particular with incomplete coverage or incomplete protection against infection and transmission, really contribute to the herd immunity and eventually end the pandemic? So if we vaccinate 60% of the population with an incomplete protection against transmission, the true herd immunity, or in other words, the true vaccine coverage to really reach a meaningful herd immunity will probably be much higher, as I alluded earlier. Could vaccines with high vaccine efficacy against symptomatic disease, but incomplete vaccine efficacy against asymptomatic infection potentially even increase transmission? So if you vaccinate and you transform vaccinated person that would normally have experienced disease, not experience disease based on the vaccine, and remain asymptomatic upon infection, they would not know about their infection and still potentially run around and infect others. So there is, even theoretically at least, the chance that vaccine efficacy against disease without vaccine efficacy against infection and transmission, theoretically even increase transmission. It would obviously still prevent disease depending on vaccination coverage in the population. Can we expect, now moving forward, what can we expect from imperfect match of vaccines and circulating strains? As you know, we have vaccines currently in use that are based on the original variant, but there is more and more new variants emerging and circulating with reduced neutralizing capacity of those vaccines. How will this translate into potential effects against infection transmission? This is also something that still needs to be investigated. How will all of this be then finally translated in public health recommendations and vaccine prioritization? And as I said before, even the use of influenza vaccines for decades so far has not stopped seasonal transmission so far. The COVAX clinical development SWAT team has organized a workshop on transmission and infection on 17th of December, and I'm just putting here the link for anyone who's interested in the full report. And we will also provide future support for vaccine developers on these questions. With that, I thank you very much for your attention, and I'm very happy to take further questions at the Q&A session. Thank you.